اوكي.
اي نعم دكتورة واضح.
بس نشوف إذا anybody is waiting. اوكي شباب، المرة السابقة احنا وصلنا we were discussing a list of congenital abnormalities affecting the gastrointestinal system of the baby. The other congenital anomaly is congenital hypertrophic pyloric stenosis, which is defined as hypertrophy and hyperplasia of the pyloric muscles of the stomach, definitely. It is a frequent congenital anomaly with an incidence estimated as 3 cases per 1,000 live birth. It is observed to be affecting males more than females. And 30% of the cases occur in the firstborn baby in the family، يعني بالطفل الأول بالعائلة. More common in prematurely born babies. There is some genetic predisposition بمعنى there is a familial incidence. In addition, there is environmental factors. There are environmental factors that affect the occurrence of this disease. So this is a simple diagram showing what's the core problem in this condition. It is a hypertrophy and hyperplasia of the pyloric muscles of the stomach, leading to obstruction to the stomach outlet. Again, this is the normal pyloric sphincter, and this is the hypertrophied pyloric muscle. How does it manifest? The classical presentation is at the age of 3 to 6 weeks of life, when the baby starts to develop immediate postprandial, non-bile stained, often projectile vomiting. So although it is a congenital anomaly, it doesn't start soon after birth for an unknown reason. Usually the clinical manifestations become clear around the age of 3 to 6 weeks of life in the shape of vomiting. And this vomiting usually occurs postprandial after feeding. It is not bile stained because the obstruction is above the sphincter of Oddi, so it doesn't contain bile, and often it is projectile. Projectile vomiting, frequently it denotes obstruction of the pyloric outlet in any way. And another characteristic of the baby is that he demands to be refed very soon after vomiting. So he is named as a hungry vomiter because he is not sick. He doesn't have an infection, for example. So his appetite is normal and his energy is normal. Soon after emptying with vomiting, he asked to be refed very soon. He is not nauseated. From the clinical manifestations, the mother may notice active peristaltic waves progressing across the upper abdomen of the child, usually starting from the left side of the abdomen to the right side, just before emesis. Before he develops vomiting, the mother may notice that there is a wavy movement affecting the upper abdomen of the child, usually starting from the left to the right، لأن هو هذا البوزيشن مال الستومك فهي وياه. And this picture demonstrates what we were describing. This is the active peristalsis. It may be seen just like that as active waves. This occurs when the stomach is full, after the baby have been fed and just before vomiting. This active peristalsis may be seen. And this actually, this is the basis of the the bedside diagnosis of this condition when we give what is called a test feed. We expose the abdomen of the baby and we try to feed him while sitting beside the right side of the bed of the baby. Soon after he finishes his feed, just before vomiting, usually this active peristaltic wave is seen. So definitely evaluation starts from the history of vomiting, starting at a certain age, and it is non-bile stained. It follows the feeding very quickly. Within a few days, the vomiting becomes evidently projectile. And another part of the test feed اللي حكينا عليه, in addition to visualizing the abnormal peristaltic wave affecting the upper abdomen of the baby, soon after vomiting, the examiner will be able to feel what is called the olive-shaped mass in the upper abdomen to the right of the midline or to the right of the right rectus muscle. This olive mass, it represents the hypertrophied pylorus. These are the sequence of the test feed. You give a feed to the baby and you sit beside him, usually better to be located at the right side of the bed. Soon after filling his stomach, he will be able to see the peristaltic wave traveling from the left to the right side of the upper abdomen. And soon after vomiting, place your hand, your right hand, at the right side of the right rectus muscle in the right hypochondrium. And then you will be able to feel the olive-sized shaped mass, which represent the hypertrophied pylorus. And this is usually enough for the diagnosis. In addition, especially if the presentation is delayed and the family did not seek medical consultation in the proper time, the baby will be suffering from weight loss and failure to thrive.
دكتورة العفو، اكو طلاب جاي ينتظرون بالويتنج روم، اذا ممكن توافقين عليهم.
اوكي شو ما اجاني اشعار اني هذه مريم زين. So delayed presentation, delayed consultation, the baby will be affected by weight loss and failure to thrive. And due to the persistence of the vomiting, frequently the baby will be in a state of variable degrees of dehydration. So this is what I was describing, the test feed of the baby. We try to expose the trunk of the baby and we give him a feed while watching initially the upper abdomen. When the stomach becomes full, there will be an abnormal peristalsis in the upper abdomen. Soon after he vomits, place your hand just below at the right hypochondrium. You will be able to feel the olive-shaped mass. This is another demonstration. This is a delayed presentation because the baby is emaciated. As you see, he is skin and bone due to the persistence of the vomiting and dehydration. Now he is receiving his feed. The upper abdomen is clearly full and there is a clearly defined stomach protuberance. So this is the distended stomach, and just wait. Soon after he vomits, place your hand at the right hypochondrium. You will be able to feel the olive-shaped mass at that time. So another peculiarity with this condition that with the progression of the dehydration and the persistence of the vomiting, there will be a peculiar metabolic deficiency in this baby due to the persistence of the vomiting. And usually they are found to be suffering from a state of hypochloremic metabolic alkalosis. Hypochloremic يعني low chloride level in the blood with metabolic alkalosis. In addition, due to the loss of a large amount of the gastric hydrochloric acid, hypokalemia, initially it may not be significant, but with time, usually they develop very gross and severe hypokalemia. So the expected metabolic changes in such babies due to the persistence of the vomiting, and the baby will lose both the stomach content and the hydrochloric acid present in the stomach. So the stomach fluid itself, it contains sodium, potassium, and chloride. There will be a deficiency of these three electrolytes. In addition, due to the loss of a large amount of the hydrochloric acid, there will be a state of metabolic alkalosis, which is hypochloremic لأن احنا بدنا نطلع HCl هنا. In addition, احنا قلنا هو صار عنده deficiency بالصوديوم, بالبوتاسيوم, بالكلورايد. بس ليش هنا loss of the potassium will be exaggerated with time؟ لأنه while losing the hydrochloric acid of the stomach and reaching a state of alkalosis, the renal tubules of the baby will try to correct this state of alkalosis. So it will try to retrieve, يعني reabsorb the hydrogen ions in the face of excreting another electrolyte instead of the hydrogen ions, واللي هو البوتاسيوم. فمحاولة من الrenal tubules to correct the alkalosis, it will try to reabsorb the filtered hydrogen ion from the renal filtrate and excrete instead of it potassium ions. So this is why the loss of the potassium will be exaggerated, not only what is residing in the stomach fluid as potassium, but in addition, due to the renal compensation, further potassium will be excreted in the urine in the aim to retrieve some hydrogen ions and correct the state of metabolic alkalosis. So this strip, it represents the acid-base analysis, which is frequently done in our hospital wards and in any pediatric hospital. This study is usually done either on venous blood or on capillary blood sample, اللي هي a very minimal amount of blood, and it gives a lot of information اللي هي very useful regarding the electrolyte profile in the plasma of the patient and the acid-base status. So as you can see هنا, potassium is on the low side لأنه normal 3.5 up to 5, so it is lower than normal. Chloride also is low لأنه normal هو 95 up to 110. Plasma pH is high لأنه, as you know, the normal plasma pH is 7.35 up to 7.42. 37% up to 7.42. فهذه surely it is alkalosis لأنه it is higher than the normal plasma pH with a high level of serum bicarbonate. The normal level of bicarbonate is something between 20 and 28 up to 28 milliequivalent or millimole per liter. هنا دا تشوفوها 40. فهذه الصورة تمثل high plasma pH, high serum bicarbonate, and low potassium and low chloride level. فواضحة؟ إذا أكو بها إشكال حتى نوضحها قبل ما نعبر other slides. انتوا اهتموا باللي أنا أحكي، أحيانا السلايد يحوي أمور ما مطلوبة من عندكم. frequently هذول البيبيز they may present also in addition to the vomiting and failure to thrive and dehydration and this metabolic alkalosis. Sometimes they present with persistent, prolonged, unconjugated jaundice. And this persistence of the unconjugated hyperbilirubinemia is because of the empty intestine of such babies. ما دا يوصلها شيء اللي بالstomach غالبا دا يصير بي vomiting. فالemptiness of the small intestine, it will enhance activation of the enterohepatic circulation. يعني الbilirubin that is excreted from the liver to the intestine in order to be excreted with the feces. In addition, it will be more reabsorbed لأنه الintestine فارغة. It will be reabsorbed back into the blood circulation and shifted back to the liver. فهذا اللي نسميه active enterohepatic circulation. There are some associated congenital abnormalities like malrotation of the midgut, which is commonly associated with this anomaly. So what about the diagnosis? Definitely the diagnosis starts from the history اللي مرينا من خلاله. وإحنا قلنا upper GI obstructions ممكن من الماترنال history ناخذ history of polyhydramnios. بعدين الكاركتر مال vomiting، الأونست مالته كلش مهم، التايمينج مال الفوميتنج، لأن إذا تذكرون مقارنة بالجاستروإسوفيجيال ريفلكس إحنا قلنا هناك الفوميتنج starts very soon after birth من the first few days of life. وإذا هو المايلد البناين form usually the baby continues to thrive well، يعني يحافظ على وزنه الطبيعي. And usually again it is not associated with bile, it is not bile stained. هنا vomiting day يبدي at the second or third week of life, again non-bile stained. With time it turns to be projectile, but if the diagnosis is delayed, the baby will present with severe weight loss and failure to thrive. Weight loss معناته اللي عنده فقده. Failure to thrive يعني مدى يزيد، مدى يسمن. Both are common in such conditions. So on examination, you need to look for the olive mass اللي وصفناها. فهذه يحتاج له test feed، يعني أقعد يمه expose the abdomen and try to feed him while you are watching initially for the abnormal peristalsis. Soon after vomiting, try to palpate for the olive mass. And actually, no surgeon is allowed to do laparotomy to such babies before he feels by his hand this olive mass. A supportive, useful diagnostic tool هي ultrasound or upper GI contrast. الكونتراست نقصد به الباريوم study، الباريوم ميل. But nowadays, actually, we don't need to do the barium study with the radiation exposure اللي وياها due to the efficiency of the ultrasound. So during ultrasound, what is done, they measure the length and the thickness of the pyloric canal. So when the thickness of the pylorus is more than 4 millimeters, and when the length of the canal is more than 10 to 15 millimeters, this is usually diagnostic for this congenital anomaly. بمعنى the pyloric canal is longer than normal in length and the wall is thicker. A 4 millimeter thickness, maximum normal here, and a length of the pyloric canal more than 14 millimeter is diagnostic of this congenital anomaly. So this picture demonstrates that تشوفون هذه two dark areas هاي تمثل pyloric wall. فهنا it can be measured الثيكنس هي هذه المسافة هذه if it is more than 4 millimeters and the length هذه اللينث يقصد بها if it is more than 14 millimeter it will be diagnostic. If it happens and a barium contrast study was done, what we look for in the barium study, initially there will be distension of the stomach, that تشوفون اكو stagnation of the contrast material inside the stomach, and it will show what is called the string sign. هذه اللي تشوفوها بمعنى narrow pyloric canal they يمر بها a narrow column of the contrast material. But this is not the routine nowadays. We do not need to do the barium study. So what is the treatment? The treatment actually is surgical. But before exposing them to surgery, we need to prepare them by correction of the fluid and electrolyte imbalance. اللي احنا وصفناها قلنا راح يصير عنده significant degree of hypochloremic metabolic alkalosis with hypokalemia and hyponatremia even. The alkalosis is dangerous with the induction of anesthesia because it may be followed by apnea. So it needs to be corrected before going to surgery, and the correction is usually done by providing normal saline infusion. النورمال saline راح ينطيني الميسنج صوديوم وينطيني الميسنج كلورايد. فبهالطريقة راح أعدل الألكالوسيس. أنا ما أحتاج أنطي أسيد، من أنطي كلورايد ions it will be corrected. normal saline infusion to correct the dehydration and the metabolic disturbance. Continuous nasogastric suction is done to empty and decompress the distended stomach. And the final treatment definitely is the surgical treatment. So this is a list. It will be sent to you in the future, inshallah, of the differential diagnosis of an infant with vomiting. Definitely there are multiple causes, some of them related to GI obstruction, but others are related to infection, مثلا. Even causes outside the gastrointestinal system may present as vomiting. For example, raised intracranial pressure due to different etiology, or infection in the central nervous system in the shape of meningitis or urinary tract infection. Some congenital metabolic and endocrine disorders also they may present as vomiting. And intoxication and poisoning may present also as vomiting. But this whole differential diagnosis needs to be thought of when you are dealing with a baby presenting with vomiting. So another condition that may present with vomiting, although it is acquired, it is not a congenital anomaly, but again, it enters in the differential diagnosis of vomiting in infants and young, children. So this problem is intussusception, which is defined as telescoping of part of the intestine into an adjacent distal portion. Telescoping يعني تداخل يصير، وهي بالعربي يترجموها تداخل الأمعاء. نقصد a proximal part of the intestine يتداخل in a distal part. هنا مثلا اللي هو most frequently the distal ileum is inserted, invaginated inside the cecum. This is the intussusception. But it may occur at even other parts of the intestine, مو بالضرورة بالإليوسيكال area. What is... نعم.
يعني ما يصير distal proximal بس proximal distal؟
Frequently yes, proximal inside the distal، مو العكس. لأنه الباثوفيزيولوجي مالتها إيش؟ هي sometimes active peristalsis for any reason, that will enhance this process of invagination. What matters, with this invagination, as you can imagine, the mesentery of the area, the affected area, will be constricted due to this process of invagination. And the mesentery carries the blood supply to this area. So blood supply will be impaired to this affected area of the bowel. And with time, this may end in ischemic necrosis. So initially, the condition presents in a shape of intestinal obstruction. There will be abdominal pain, there will be vomiting, and gradually failure to pass motion. هذه الصورة اللي classical توحينا دائما إنه there is intestinal obstruction. If we do not correct the problem early and prevent ischemic damage to the bowel, then ischemia will affect certain areas, and the ischemic areas may be liable for perforation. So with advanced neglected conditions, there will be perforation of the bowel and soiling of the peritoneal cavity. That is, the patient will present in a state of peritonitis. So, what are the leading causes for intussusception? Actually, it is very common, affecting infants and young children up to the age of 3 years. هنا ممكن يصير ال idiopathic type of intussusception. Between the age of 3 months up to 3 years, the idiopathic type of intussusception is frequently seen. Idiopathic, it means it occurs for unknown reasons, and frequently it follows infections, a local GI infection, gastroenteritis, or even intercurrent respiratory illness. And the explanation is thought to be that with infection, there will be sort of hypertrophy of the Peyer's patches, اللي هي lymph gland areas inside the intestinal wall. It will be enlarged with the infection, so it will act as a leading point that drags the intestine and invaginates a part into the other. When intussusception occurs outside this age range, يعني either below 3 months of life or after 3 years of age, usually we deal with it as secondary form of intussusception, and we try to dig for a leading cause. And the leading cause may be, for example, a polyp in the intestine, or a mass, a tumor mass in the intestine. Both of these, they may act as a dragging point اللي تسحب جزء من الانتستين وتسوي له invagination in another part of the bowel. واضحة? So how does it present? The child appears initially suffering from intermittent pain that is severe and colicky. Abdominal pain, I mean. Intermittent, so in between, the child returns back to his normal. He returns as comfortable and happy child. But intermittent episodes of severe and colicky abdominal pain, during which the child will often draw his legs up. يعني يلم رجليه يعكف رجليه على بطنه. The episodes may recur 2 to 3 times per hour. Vomiting is a prominent feature, and with time vomiting turns into bile stained. لأنه إذا نتخيل الفريكوينت سايت هو إليوسيكم، فمعناته الأبستراكشن راح يصير هناك. It is below the sphincter of Oddi. So with time, initially the vomiting will be normally colored. The child will empty the stomach content, and thereafter it will be bile stained. So a bile stained vomitus is a late sign. معناته the process مال الانتسسبشن صار لها فترة هي. Bowel movements, again, إذا نتخيل الobstruction بالiliocecal area, initially the child may be able to pass normal bowel motion, content that is present below the cecum. He will pass normal bowel motion, but with time, via strangulation of the mesentery inside the intussuscepted area, there will be blood and mucus with the stool. And this blood is usually fresh and bright blood with mucus, and frequently it is described as currant jelly stool. الكرنت jelly هي مربى الكرز، لونها يصير bright red و glistening لامع، فيشبهون bowel motion مع intussusception as currant jelly stool اللي هو denotes mucus اللي دا ينطي glistening color and fresh bright blood. So this is what is meant by the red currant stool. So with the progression of the obstruction, when the child empties all what is present below the cecum, كل اللي موجود بالكولون تفرغ, the child may continue only passing the currant jelly stool without feces. يعني صار total intestinal obstruction, فرغ ما موجود below the obstruction. Initially normal bowel motions, بعدين صارت blood stained, and thereafter no feces will be passed, just the blood and the mucus. And the child will be in persistent pain. بالبداية كان intermittent, يرجع فيما بينها back to normal. بعدين with progression there will be persistent pain and crying. Frequently the child flexing his knees against his abdomen. And this is the advanced states of the obstruction. هنا نقدر نشوف plain X-ray of the abdomen. عندنا no gas in the lower bowel, lower abdomen. And sometimes بالerect position ممكن نشوف multiple air fluid levels. One of the important diagnostic tools, again, is abdominal ultrasonography. This is because it is harmless, non-invasive, and no radiation exposure. And it is very informative. What we expect to see in conditions of intussusception, when we have a cross-section of the affected area, it will give us what is called the target sign. اللي هي we mean by successive layers of the intestine, one inside the other, اللي هي هذه يسموها target sign. So it is very diagnostic for intussusception. Here, we may benefit either from barium enema or even air enema. Both enemas will be diagnostic and therapeutic at the same time. So with barium enema, that is injecting the barium as an enema, what we will see that the barium column stops at the level of the intussusception. يوصل للمنطقة اللي بيها intussusception ويوقف, ما يقدر يمتد أكثر لأن هي المنطقة obstructed. And in this area, one may be able to see what is called the coil spring appearance. The coil spring appearance, which denotes the passage of small amount of contrast اللي هو الباريوم in between the layers of the intussusception. فمرور هذا الخيط الرفيع من الباريوم هو راح يرسل لنا الcoil spring appearance. So عندنا هنا stopping of the barium at the area of the obstruction with evident cupping of the end of the barium. دا تشوفوها النهاية مالتها مقعرة لأنه الماس مال intussusception نعطيتها هذه configuration, and there will be a thin line of barium giving us the shape of a coil spring appearance when it passes in the mass of the intussusception. واضح? So how do we treat them? Our aim is to reduce back the intussusception. يعني نعكس العملية, نفك intussusception احنا. Before the bowel becomes necrotic. يعني إذا لحق لها before the ischemic damage, we will try to reduce the obstruction. مجرد نفك obstruction. Then when do I know that we have reached the state of the ischemia and the necrosis? Usually from the time الonset, either within the first 24 hours, من نوصل 48 hours and above, we do not attempt reduction. ما نحاول نسوي reduction اللي هو نقصد به close reduction. إما through the barium, إما air enema, مجرد air enema, and they follow it by fluoroscopy. Fluoroscopy يعني radiation. It is followed by fluoroscopy. فالinjected contrast أو injected air راح ينطينا هالصورة إذا عندي contrast. Wait for a time. The barium will continue pushing the obstructed area until it opens. فراح نشوف ويا الفولو اب مال الفلوروسكوبي انه الباريوم امتد forward proximally until it opens the whole colon and the dye extends covering the whole intestine. Again, this may be done with just air enema without contrast, and it will be followed easily by fluoroscopy also. بس هذا كله نسميه closed reduction. والمسموح به انه اسويه within the first 24 hours, contraindicated to be attempted at 48 hours and above, and contraindicated if there are signs of peritoneal irritation, يعني actual perforation صاير. شلون اعرفها هذه؟ If the baby is having high fever, high temperature, this is a sign of peritonitis. If the baby presents in shock, لأنه peritonitis may push the patient into shock. If the abdomen is tense with gardening, يعني high signs of peritoneal irritation. فإذا التايمينج 48 hours and above, إذا أكو high fever, إذا shock state, إذا tense abdomen, هذه كلها contraindication for closed reduction. But if I reach the child early enough, the enema, the closed reduction is diagnostic and therapeutic in most of the cases. Only rarely the closed reduction will fail and the patient will need laparotomy. And in laparotomy, if the bowel is healthy, all what is done is reduction of the intussusception and fixation of the mesentery to prevent the recurrence of the problem. But if the bowel is necrotic, ischemic, usually the laparotomy, it includes only what is called as the peritoneal toilet, a wash to the peritoneum, and they fix the drainage with the institution of broad-spectrum antibacterial therapy until a corrective surgery as a second stage surgery could be done, and to resect the ischemic bowel and perform end-to-end anastomosis. So some of the side effects of the closed reduction, it is liable for recurrence. But at the same time, it is safe ومحتاج هنا general anesthesia, or it is not free of the complications of the anesthesia. The benefit of the surgical reduction is that it prevents recurrence of the problem. Resection is only done when there are ischemic areas in the bowel. So what if you decide that the patient is due for surgery من البداية؟ أنا ما من حقي أسوي له closed reduction للأسباب اللي عددناها سابقا. فإما حاولنا manual reduction و failed، إما contraindicated كان. In both conditions you need to rehydrate the child لأن frequently هو dehydrated من persistent vomiting و lack of feeding. Antibacterial therapy preoperatively needs to be started, and then going to the surgery. اللي ما احكي لكم اياها السلايدات انتم ما راح تكون مطلوبة من عندكم. fine. So that's it. You are through. شباب أنا دائما أطلب منكم أن تسجلون أسماءكم على الشات ليست رجاءً.